Welcome everyone, and thank you for joining us. It's 2 o'clock, so we are going to get started in the interest of time. My name is Josie Gibson, and I'm the Director of Education with OARC. And just before I introduce to you our guest speaker today, I'd like to take this time just to remind each of you that your lines have been muted to minimize background noise. And at the end of the presentation, there will be an opportunity for a Q&A session. So we do invite you to send your questions in through the chat box, and we'll do our best to ensure that these are addressed at the end of the session. The chat box can be found at the bottom of your toolbar. And lastly, I wanted to mention that this session is being recorded for educational purposes. So without further ado, I'd like to welcome and introduce to you Cathy Fooks, Ontario's Patient Ombudsman. Cathy is going to be sharing with us what her office has heard during the first wave of COVID-19 and some of their recommendations to improve resident, caregiver, and staff experiences in the case of future outbreaks. So with that, I'm going to now pass it over to you, Cathy.
Okay, thank you very much, Josie Lee, and good afternoon, everyone. I hope you and your families are safe and well during this second wave of COVID as we wait it out. If I could have the next slide, please. Before we start the presentation, I just wanted to acknowledge the experience that all of you have been having for the last number of months. When I had a discussion with the OARC board a few weeks ago, I asked them to describe their experience during COVID, and these are the words that I heard. So I just wanted to acknowledge this, and obviously whether you've been in a home with an outbreak or not, you've been separated from your family and your friends for a very long time. And I understand how isolating and lonely that must have been. So I'm very honored today to be able to present this information back to you because it is because of you and your family members and some of the staff in the homes who came to our office. We were able to play back to the healthcare system what has happened to you. May I have the next slide, please? So what do we do? What does the Patient Ombudsman do? Well, we've been in existence now for 4 years. You may remember that Christine Elliott, who is now the Minister of Health, was the original Ombudsman, and then she stepped down to run again as a politician, and for a couple of years there wasn't one. And then, but the office still functioned and took complaints, and then I joined in July of this year. So what we do is we resolve and investigate complaints about healthcare experiences, and that can include complaints about long-term care facilities, public hospitals, and home and community care that is arranged by the LHIN. So there are many things that we unfortunately cannot look at. We can't look at community-based services. We can't look at actual home care providers themselves. We can only look at the LHIN piece of it. And obviously, if there are complaints about specific healthcare professionals, they go to the professional regulatory colleges. We are what's called an office of last resort, because if you have a complaint about your home, you have to try and resolve it at the home level first. And if it doesn't get resolved to your satisfaction or your family member's satisfaction, then you come to our office and we get ourselves involved. We try to help patients, residents, and families navigate the healthcare system. It's complicated. Even the complaint system itself is very complicated, and there's many parts to it. So often people come to us who we can't actually take a formal complaint because it's not within our jurisdiction, but we will try to help navigate you to the right place. Our job is to look for fairness for you, and also fairness for the healthcare system. And one of the things we can do is we have a public platform, and we're able to shine a light on issues of concern and make our findings public and share them with the public and government policymakers and healthcare system leaders. Next slide, please. So early in the spring, or early March, I guess, we started tracking COVID-related complaints as a new category for us. And from the middle of March to the end of June, we received 568 COVID-related complaints. Now, my office has 3 investigators and 6 early resolution specialists. So this was quite a huge increase in volume for our small team. And almost half of the complaints that came in the door over that time period were COVID-related. And remember, this was a whole new environment that nobody had any understanding of. So we were faced with complaints about a virus people knew very little of, and clearly plans were not in place to deal with it. Since we've been open in 2016, only 10% of the complaints that we received have actually been from the long-term care sector, and that totally changed in the spring. And we had a 370% increase in complaints about long-term care. And what we were hearing at the time began to really mirror the reports that we were seeing in the media, particularly when the Army was releasing its site, or the Armed Forces, I should say, was releasing its site-specific reports. The kinds of things that they were seeing when they were going into the homes were the sorts of things that we were receiving complaints about. Next one, please. So this table shows you what we heard. This is all of our COVID complaints. So again, it's our 3 areas: home and community care, long-term care, and hospitals. I'm going to focus just on the blue, on the long-term care homes, because that is of what you're interested in. So no surprise, the first category at the top there was visitation. So this was clearly coming from residents, but also many family members who all of a sudden were locked out of homes and were not able to see their family member, after being, expecting to be in there almost on a daily basis for visiting and helping out, and all of a sudden you couldn't go. The second one, infection prevention and control, we heard a lot from staff about this in terms of concerns about the processes that homes were using, that they weren't using proper processes. They weren't isolating the positive and the negative patients. They were moving people around. They weren't taking on and putting on and taking off the equipment properly. So lots of concern about how that was working. And in fact, staff themselves told us that they didn't feel they'd been trained properly, and that while infection control has always been part of a nursing home protocol, particularly in influenza and flu season, this virus was something we'd never seen before, and the rapidity with which it was being transmitted, the existing policies just weren't up to snuff. Communication, again, very much from families, pretty desperate to find out what was going on, and coupled with not being able to see your family member and then not being able to get specific information was very distressing for people. Obviously, they were being directed to websites which had very general information about what was happening in the home, but they wanted to know exactly what was happening with mom or dad or husband or wife or whomever it would be. And that was very intermittent or non-existent. Quality of care, this again was more of a staff complaint to us, that they were concerned once the families were banned from the homes, very concerned that the level of care for residents was going down. And we were hearing stories of residents becoming quite malnourished and dehydrated, very confused, because people were being literally locked in their rooms, staying in bed, getting pressure ulcers, and obviously very little mobility because they weren't able to walk around. So very concerned about the safety and care for residents. Staffing was a huge issue, and this was right across the system, really. Once, a couple things happened here. Once the government said that staff, PSWs in particular, could only work in one home in order to, prevent cross-contamination. That made it very difficult for homes because, as you know, most PSWs work in multiple locations in order to earn an income. And so once that rule was changed, and then also staff were getting sick, many homes had, one PSW for 30, 50 residents. It became quite stark. Discharge and transfer, this was largely about people being transferred to and from hospital. Certainly at the beginning of the pandemic, hospitals were quite worried about a surge and not having capacity. So they were certainly trying to get people out where they could. So often people who were waiting for placement, either to go home or maybe into a long-term care facility, got sent to a facility that had an outbreak, which was a real concern to the patient and obviously to their family. Testing was very much about access to testing protocols, particularly when homes were supposed to be testing all the residents and weren't. Access was related to programs, so regular daily programming in the home that all of a sudden just got canceled. So, anything that was, could have been social, could have been physical exercise in a congregate group setting was canceled. PPE, this was very much lack of PPE. So homes reporting that they didn't have enough supply, weren't sure where to get them, and also telling workers to come in even if they couldn't provide them with PPE, which was certainly of concern because we know now what the evidence on what if you wear a mask, what that does in terms of curtailing transmission. And then delay was, this was more related to hospitals because it was canceled surgeries, but delay in the case of a long-term care home was actually somebody who was at the top of a list for placement, and then that was postponed. Okay, can I have the next one, please? So we did, as I said, we did start to hear a lot of complaints in the spring, but a number of these were whistleblower complaints. So these were staff working in the homes who were very concerned about what they were seeing. This is not common for our office, so this was new for us, and they were sharing pretty serious concerns about what was happening to residents and staff. But the other issue with this was they were also concerned about losing their jobs. So they came to us anyway, but it's something that we felt needed to be dealt with, and it's why one of our recommendations just does deal with this issue, and we'll talk about that more later in the presentation. Can I have the next one, please? Okay, so what we did in the spring was, the first thing we did was to change our internal process so that we realigned the way that we were handling processes so that our entire investigative team could focus on the serious complaints. All urgent complaints were escalated up appropriately, so either it was directed right to the home itself or to the LIN leads for the region or the public health unit. So it kind of depended on what the issue was, but we figured we were one of the few organizations that had people coming to us that were inside the facilities. And so, you know, this was one of the few places where information was being collected in a timely way, and we wanted to make sure people knew about it. We also notified the Minister of Health and the Ministry of Long-Term Care and Ontario Health, because we wanted to make sure that whoever was sitting at the planning tables, and I guess I need to make clear that Patient Ombudsman does not, that's not our role, but we want to make sure that we could give the information to them as quickly as possible. We then launched a public campaign for complaints to try to better understand the issues and to make sure that we were hearing from everybody who wanted to tell us their story, which then resulted in another large number of complaints coming in. And then we also made multiple mandatory reports to the inspections branch of the Ministry of Long-Term Care, which we are required to do. Next one, please. So following our appeal, we received another 150 complaints. And interestingly enough, we did receive complaints about 90 different homes that definitely had an outbreak, but also 29 homes that didn't. So even in homes where there wasn't an outbreak, there were still a lot of concerns about largely around visitation and communication. And then that graph on the right just actually shows you the number of complaints over the period that we were talking about, and the green is the COVID, so you can see how it spiked both at the beginning and then when we did our public appeal. Okay, next one, please. So then in June, we announced our systemic investigation, and I guess I should stop and just explain a little bit about what that means. So the report that we were talking about now is not actually the investigation report. This is a report that actually talks about the complaints that we heard and describes the stories. The investigation itself is underway, and it will probably conclude sometime next year. And it involves very specific steps. So we sit down as a team and we write out a planning document in terms of all of the elements that will be in the investigation. And that includes evidence collection, so we can subpoena documents. It includes witness interviews. So we're going to be going into a number of homes to actually look at very granular level information and see what happened in those specific homes. We then analyze the evidence, we vet our findings, and we make our recommendations and have a public report. As well as doing the home level analysis, we're also going to do a number of surveys. So we will be doing a resident survey, and OARC has very kindly agreed to help promote the survey when it is available. We'll be doing a family survey, and Family Councils Ontario is going to do the same so that we can get hopefully a good number of people responding. And we're also going to do a staff survey. So we're really trying to get as broad a picture as possible about what happened in the homes, not in the spring, but also ongoing. And then the final report, as I say, will be made in 2021. We're also quite aware that there are a number of other parties that are working in this area, and in particular the commission, the Long-Term Care Commission. We're working quite closely with them so that we're not duplicating effort, and we're also not bumping up against each other in terms of reports, because they have a hard deadline of April and we have a little bit more flexibility. We will also be sharing the surveys, the draft surveys that we're sharing with you with them so that they can see what we're asking. Okay, next one, please. So again, just to remind you, the categories that we heard complaints about, so IPAC, visitation, communication, quality, staffing, discharge and transfers, and PPE. Okay, next. So I'm going to go through the sort of complaints that we've heard in the different topic areas. So this is one in which a complainant came to our office because she was quite concerned about the lack of infection and prevention and control in her mom's long-term care home. Her mother had been tested positive, and yet she was moved from an area of the home with active COVID patients to a safe area because she hadn't received her results back. It turned out she was positive, and so the complainant, and so now she's in an area of the home where there are non-COVID patients. So the complainant was very concerned about the risk to not just her mother, but other residents. And they also reported that staff were not wearing PPE in the area of the home with the positive residents. So clearly there's real issues there about the cohorting of residents. Okay, next one, please. Visitation restrictions, and these ones are so heartbreaking. So this is an example of somebody who used to provide daily care for his mom at night. So he was very much part of her nighttime routine, going to bed and so on, getting her ready. And he was reduced to a one 5-minute virtual visit a week. Problem being that he wasn't considered an essential visitor. His mother has advanced dementia, so the idea of a virtual visit and using the screen was pretty difficult. So he really was cut out of her care and also direct communication with her. Next, please. So staffing shortages. So this was a concern about, turns out it's a mother-in-law who was losing weight during lockdown because she was receiving assistance with eating from the family, and then the deal was, well, she'll have a tray delivered, but we can't guarantee that anybody can help her actually eat the food. So this was not so much a COVID specific complaint, but it was a complaint about the effects of the policies inside the home because of COVID and what that was doing to people, even if they didn't have the virus, but they were still experiencing levels of neglect, dehydration, and in some cases starvation because the staff weren't available to support residents. Okay, next one, please. Poor communication, again, another heartbreaking one. This was an example of a complainant who knew that her mother was sick, wasn't sure, wasn't sure if it was COVID or not, but definitely had some of the symptoms, and wasn't getting any updates from the home. And then out of the blue, she receives news that her mother's died, and she had no opportunity to say goodbye. And we've heard this over and over again. The last couple of days, we've done some town halls with the actual complainants who came to our office, and unfortunately this was a story we heard multiple times. Next one, please. Okay, so I'm going to go through our policy recommendations now. There's only 4 of them, so we tried to keep it short, but they're very much based on the complaints that came into the office. Can we have the next one, please? Oh, go back. Yeah, perfect. So this is the guts of the special report, and the reason that we decided to go early, because originally people were thinking we were going to have an investigative report, and we weren't ready to do that. That takes much longer time, but we just felt that we had such a volume of complaints to our office and so many people in a lot of pain that we really wanted to make sure that as quickly as possible we could feed this back to the system. In particular, knowing that we probably would have a second wave in the fall, that we could at least try to influence the plans that were being put in place. So there were 4 things that we recommended, and I will go into each of them in more detail. But essentially, we were looking for contingency plans, a change in the visitation policy, resources for communication, and some whistleblower protection. Okay, let's go to the next one. So in terms of the contingency planning, so this was something that really did become apparent to us that, excuse me, my throat is very dry because I've been presenting this material for the last 2 weeks nonstop. So I'm trying to drink water and talk at the same time. We really could see that homes were not prepared, that they were definitely overwhelmed by the rapidity with which the virus would go through the homes. So second wave, we really want to make sure that they had a partner, an organization in their community that could really provide pretty intensive support for infection prevention and control. And whether that was a hospital or a public health unit or even other homes who were doing a good job, we didn't specify which, but we just felt it was quite important for organizations to know who they could turn to. And interestingly, in the last couple of weeks, I've been interviewing a number of hospital CEOs who've been involved in the management orders in taking over a home, and the level of detail that they've taken me through in terms of what they had to provide was quite an education. So often they were sending in a team of a dozen people to go into a home on a daily basis to do everything from cleaning to training to audits on protocols, and then going back the next day and doing it again. So clearly the homes needed a lot of support, and there's no reason to think it wouldn't be the same second time around. So being able to identify somebody who could help, an organization that could really help, whether there was a management order or not, that didn't really matter. They just should have, they should know who their partners could be. Certainly they needed to have a contingency plan for staffing, because there, again, there's going to be similar issues with staffing. The rule of working in one home hasn't changed. And so they need to have other ways in which to tap into other agencies for staff. The transfer plan for sick residents really does need to be spelled out. There was quite a bit of confusion, particularly when families didn't know somebody was being transferred, so didn't know where they were. So that protocol has to be in place. And then also making sure that staff receive up-to-date training regarding IPAC and PPE. And there are lots of resources available for this, many of them online. So it's just making sure that the home has a good policy on training for staff. Okay, next one, please. So we really didn't want to see the system go back to where we were in the spring, where there was no visitation whatsoever. And now I think there's reasonably good evidence. There's a number of good documents and people around who are very clear that if it's an evidence-based approach, it's proportional to the risk that the visitor poses, then with appropriate safety precautions, there really has to be allowance for a number of essential caregivers. I know at the moment, in the hot spots like Toronto and Ottawa and Peel, we're down to one. And I know families are finding that hard. It's hard for the one person. If that one person can't go, there can't be a substitute. So that's been difficult. In other areas, it's still 2, which makes it slightly easier, but at least it's not 0. And then the other thing, because of the stories that we heard about people not being able to say goodbye, that there has to be an exception, whatever the rule is, on compassionate grounds. So we're glad to see that there's some visitation, that we haven't gone back to 0, and are hoping that doesn't happen. Okay, next one. So given that there is limited visitation, then there really has to be some dedicated resources for communication. We really want to make sure that it's a timely, personal, whether it's a phone call or it's an email, it's an update on how your actual family member's doing, not just a broad general communication about what's happening in the homes. I mean, this I think was probably one of the highest sources of anxiety for people when they went day after day, not knowing, frankly, if their family member was even alive. So this communication is really essential, and we do think the government should ensure some resources to homes for this, not just for frontline staff, but for communication as well. Okay, next one, and this is the last recommendation. So this is, as I said earlier, this is because we had people coming who were a little concerned about losing their jobs, and probably if there had been clear protection in place, we would have heard from more staff members, although we thank the staff who came forward because they did it because of their concerns. But there isn't a general protection for healthcare workers who bring forward concerns in good faith, especially during an emergency. And the Long-Term Care Commission, because they wanted to hear from staff, had to go and get special permission to be from the government to be able to provide immunity to staff who came forward. But if this general protection had been in place, they wouldn't have had to do that. So we do think that this is an important piece, whether it's pandemic or not. It's just the ability for people to come forward if they're concerned about something that they're seeing in their workplace. Okay, next one. So that's pretty much the end of my formal presentation. We still would really, again, like to thank the people who came to us, residents, families, and staff, to tell us what they heard. Please continue to do so. You may be experiencing now with second wave further issues, and where we can, our staff are available to try and help. That is the phone number there. It's toll free. We have English and French speaking staff. So please don't hesitate to contact our office if you need assistance with something. So thanks for listening to me talk to you for the last 27 minutes. And I'm happy now to have a bit of a discussion, to hear your stories, however you'd like to handle this. So I guess I'm going to turn it back to Josie Lee.
Thanks, Cathy. So at this point, the chat box is now open. So anybody on the line who would like to send in comments, questions, stories, as Cathy just mentioned, please do so. I can also try and unmute your line if you would like to speak up directly. So I'll just give everybody a couple of minutes to gather their thoughts and questions, and we will begin addressing them.
While you're thinking about it, I guess that I just want to say, I forgot to mention this, in a couple of weeks' time, I'll be meeting again with the association board members because we're going to share with them the draft survey for residents, and we're going to be getting their feedback on the wording of the questions that we're asking and whether or not we've missed any important issues. So just to assure you that your association is being extremely helpful to us in this process of the systemic investigation, and we appreciate the time. Dee's been really helpful in organizing all of that for us.
Okay, it's Melissa here from the OARC team, and we do have Dee Lender, OARC's Executive Director, in
Great.
our audience. Josie Lee, if you could unmute Dee on your end, she would like to ask a question.
So imagine that, you get to mute your boss. That's really something.
He's actually self-muted at the moment. So you can unmute your own line there.
Okay.
Just bear with us. There she is.
Hi, everyone. Thank you, Cathy, for the last half an hour spent with us and those that we work so diligently to serve. My question to you is really organization to organization. Is there something that you can foresee OARC helping you in terms of leveraging or elevating your recommendations to government, to public, through media, etc.? Because you have said that your recommendations, while they will be timely and all-encompassing, they are not necessarily actionable.
They're not binding. Yeah, they're not binding. That's right.
Right.
Yeah. Right.
So, is there something that comes to mind that we, as the organization that represents residents in long-term care, is there something that we can do quite specifically to add more power and leverage to the recommendations?
So I think my guess would be the visitation and communication piece is really where having your voice makes a difference. I mean, I don't think it's a coincidence that when you testified at the commission, they used your words at the beginning of their interim letter last week. I thought that was extremely powerful. So I think keep doing that. Certainly, if you can, if there's any shift in the visitation policies, then I think we have to really together, talk about why that's a problem. Certainly, helping us with the survey will be extremely useful. So I think it's just a matter of whatever public support the association feels comfortable giving. We would welcome it.
Thank you, Cathy. And just, I guess, a part two to the question is a little bit of an observation. You know, early on in the pandemic, March, April, May, there was such intense focus on protecting the physical threat of COVID. And we saw almost a line in the sand where all of a sudden there was evidence that the psychosocial and emotional well-being of residents and their family members and loved ones was really taking a hit. I'm glad to see that, you know, many of the complaints that you received and that we received at OARC really hinged on the fact that it's important to protect against the physical threat of the virus, but God forbid, you know, we survive the virus and are left with thousands of people whose spirits have been broken. So I'm just wondering if you might be able to elaborate a little bit on some of the stories that you've heard that really speak to the psychosocial and emotional trauma that residents and their family members have encountered.
Well, I mean, the timing of that question is following on, as I think I referenced earlier, 2 town halls that we did this week, one on Monday and one last night. So virtual like this, with any of the complainants who wanted to attend. And it was very emotional. I mean, people have lost family members during this time period and they're grieving. They're angry. They're very depressed. You know, we had a woman whose mother is in a hospital bed in her living room because she just couldn't take it anymore. So she's got her at home and she's sleeping on the floor beside her. A lot of anger about, you know, the lack of control that people had. So these rules were put in place with no ability for families or residents, for that matter, to have a voice in what does a balance look like. It was very much one-sided, I think, in terms of the fear factor driving policies at the very beginning. And then even when, you know, things were starting to, the outbreaks were coming down, the people were getting used to new protocols, the number of cases, new cases was sort of double digits through the summer, and yet we still had these protocols in place. So kind of hard to understand why that didn't shift. I think the other piece that people have that don't understand is, and I don't mean because they can't, it's just that the policy doesn't make sense. Staff members are free to come and go, obviously, but they're also free to live their lives in their own communities, presumably being careful with their own families, but they're able to do that. Why can't family members be treated with the same level of trust? So, you know, that piece of it, I have a hard time squaring the circle on because I don't see how it's that different. So we heard a lot of, you know, heartfelt stories about how depressed people were and worried and anxious, both the residents and their families. Not everybody has the ability to use technology to communicate. So at some point in time, it was a phone call, but not able to see each other on a screen. I just, you know, people were very, very isolated and depressed. All those words I showed at the beginning of this session. And, you know, we as a society have done that. So the fact that we're back into second wave, you know, I'm hoping we don't see that level of isolation and depression, but, you know, we don't know at this point. We're certainly getting complaints again. Not so much that we can't visit. It's more around, is the visitation very confusing. So there's different policies for different regions, depending on whether you're a hotspot or not. And then the way in which the homes interpret the policies is not very consistent. So that's complicated. And now with the change in testing, where families are having to attest that, they've been tested within the last 2 weeks. Sometimes they're not getting their results back in time. So then there's this confusion about, well, what do I do now? I can't, I can't do anything about how long the test results are taking, but I did go get the test when I was supposed to, and I feel fine. And now you're telling me I can't come in. So, I think we've lost a bit of the compassionate side of things here. And, we said in our report, please put yourself in the shoes of these people and think about how this would feel if this was your family you couldn't see. But I don't know if that message has gotten through.
Hi, Cathy. It's Melissa here from OARC.
Yeah.
I just wanted to piggyback on that comment. We have a number of questions and comments coming through along that vein of visitation.
Okay.
There's a comment from Jennifer that says, we need to make provisions for essential care visitors to be tested at the same time at the home when staff are being tested. They really feel it needs to be more accessible for our family members, those essential caregivers coming in.
I think that's absolutely a good, good suggestion. And when the rapid test comes, which is not far off, that should be pretty simple. So yes, I think that, trying to make, if you're going to rely on testing as one of your screening protocols, then making it available quickly and easily for families, I think it has to be top priority.
Yes, thank you. Another question came from Sherry. How do you manage an essential caregiver that is providing care for two parents, mom and dad, who live in two different long-term care homes?
Right.
The dilemma that Sherry's facing.
Yeah, that's a tough one, right? Because the rule's supposed to be you can only go to one. So again, I don't know what families are supposed to do if you don't have any other family members who can provide care to the other parent. I'm not sure what you have to do. I think one of the things I would stress, because of these, what's the word I'm looking for? Local interpretation of the policies. One of the things our office does do is they call the home and try to walk them through what the actual directive says. Because many times we're hearing from people saying, I have the directive in front of me and the home is not following it. So we can call the home and kind of try to get them to explain why they're not, what their rationale is, and whether or not they think they're being fair. And we have managed in some instances to get people to get some administrators to say, yeah, I guess you're right. So if you're having that kind of a problem, call us. I'm not sure what we can do about one person with two family members, two parents in different homes, because it's really clear they won't let you travel between the homes, which is awful.
Yeah. Thanks, Cathy. We've got another question from Susan. As part of the investigation report, will you be looking at the long-term care homes who have had zero COVID cases for lessons learned?
Absolutely. We are hoping to find some homes. I don't know if any had zero. That would be amazing if they did. And if you know of one, please let me know. We certainly have homes that didn't have outbreak because they put some innovative policies in place. And so we are looking to try to highlight, where some homes did well, because some did. Like, not everybody had the severity of issues as the ones that we've seen in the media. So clearly they were doing something right. We are also looking at, because we get this question a lot, are you looking at whether there are differences between homes because of their ownership? So we are definitely looking at when we go into the homes to do the evidence collection, we're trying to have a mix of corporate ownership. So we've got for-profits, the chains, the nonprofits, and the municipals, so that we can sort of see whether or not there's differences, stark differences due to that. Certainly on early blush, it appears to us that the municipals have done a little better than some of the others because public health is municipal. So they had pretty rapid access to IPAC expertise that some of the other homes may not have had. But yeah, we're definitely going to be looking for homes that did well, but we're also going to be looking for innovative practices. So we would welcome if any of you have information, things that you think worked well, or if you are in a home that didn't have cases or didn't have outbreak, please I guess maybe Dee, can they let you know, and then you could pass that on to our office if that's appropriate, because we really, we're trying, but it's hard for us to get that granular level information when you're dealing with over 600 facilities in the province. So any help you could give us, we would welcome.
Great, thank you, Cathy. We also have a few more observations and feedback coming through from Jennifer. I think it's a two-pronged comment. Her observation is that essential service visitors are not always adhering to some of the rules. They are taking residents for walks, going to the dining room. There's been some issues with like non-compliance with using PPE, face masks not worn properly. And then team members are in this position where they feel like they're the bad guys. They're the enforcers if they have to suspend visitation or take any action. So
Yep, we've definitely been hearing that, and I get, I think we sympathize. I mean, I think if people are not following protocol, then that's really unfair. And if they're not going to, then they're putting everybody at risk. So that's putting the home in an awkward position. And in that instance, I think, if there was a complaint to us, the fairness protocol would probably indicate that the home is being fair by asking you to either abide by the rules or not come, because you're endangering everybody when that happens.
Exactly. We have a comment from Monica. She says, I think the essential caregiver program will definitely assist if homes enter into an outbreak. As the government will be allowing the essential caregivers to come into the home, I strongly believe there is a lot of confusion regarding the visitation policy, as each home can have a different internal process. So our goal is safety for all. We've had on-site testing for our families, which they're thankful for, but the hospital can't support this any longer. So.
So, I mean, one of the things I'd be interested if anybody's got any feedback on this, one of the things we're starting to hear about as homes are organizing themselves for essential visitors, they're asking people to sign, it's not a contract, but sign something. Let's just say an agreement for the want of a word for the moment. But the agreement specifies that they have to do certain tasks. Like you can visit, but you have to do the following things with your family member. And so the implicit sort of understatement of that is if you're not willing or can't, you can't visit. And we're starting to get some complaints about whether or not that's fair, because certainly the directive does not specify you have to provide tasks, and in some cases it would be entirely inappropriate. So I don't know if that's experience, if any of you have experienced that, but we're starting to hear families complain about the fact that they're feeling like they're being somewhat blackmailed.
Okay, I think Monica's saying that people can still visit as a general visitor if the home is COVID-free, but yeah.
Right.
Yeah,
and it's confusing, right? Like I have to read that directive many times. COVID-free, not COVID-free, a visitor or not. They've not made it simple, and then it definitely still there's the ability for each home to still interpret it sort of how they want. So there's definitely not consistency across the sector in terms of how they're implementing that visitation directive number 5 or whatever it is, the most recent one.
Yeah. Getting back to that earlier call for homes that have been COVID-free or doing a great job, we did have two people in our audience offer up home names proudly.
Okay.
The Wellington and Hamilton has had 0 COVID.
Okay.
This participant's sister is there and they've been amazing. So
Great.
that's a nice piece of information to hear. And then Mount Nemo, a Christian nursing home in Burlington, has had no cases as well. So that came from Karen. So thank you, Karen. Thank you, Susan.
Thank you. Yeah, very interesting.
I'll just make note of that in my notes here. But we certainly will look to those homes that have had some promising practices and with the hopes of sharing that.
Yeah, so that's fascinating, right? What did they do? I mean, it's not like they wouldn't have had the same environmental circumstances as everybody else. So something went really right there, which is really great to hear. And then there's some other things that we've, been looking at, like, again, back to the visitation policy. There were some places that hired family members to come in and function as staff. So instead of keeping them out, they actually brought them in and paid them. And that allowed them to see their family member. And the deal was, I think you had to also support one other resident in the home, but totally different approach to nobody can come in.
Mm-hmm. Okay, I'm just going to jump back up because I know I've missed a few of the questions that came in earlier. We had some concern around the absence of air conditioning. This is a long-standing issue in long-term care, and with COVID not being able to leave to go to a cooling room, it became unbearable for some residents. I know the OARC team received a number of these issues, and some residents went directly to the ministry action line to report conditions. But it has been unbearable for both residents and team members. Susan would like to know, is this something that can be considered, I guess, in terms of recommendations for?
Yeah. So I off the top of my head, I don't know how many complaints we would have had on that specific issue. But certainly we were well aware of it in the summer when there was a lot of media coverage of it, and whether you think the money will show or not, there certainly has been very clear financial commitments to retrofitting those homes that don't have air conditioning. But yeah, I can imagine it was disgusting for people.
Yeah. We had feedback from Jessica. I believe Jessica is in Kingston. She said at their home they have started to do COVID testing for family members, and I know this, we've heard this time and time again. If homes are able to accommodate that, family members are very pleased for the convenience of that kind of service.
That's good to hear. Just again, but I think the frustrating part is, so there's a progressive home that's trying to do the right thing, but it's not mandatory, and so a whole bunch of others don't. So like, how do we get the standard up to what the best practice is, and not leave it up to individuals to decide whether they want to or not?
Exactly. Yes. Monica shared a lot of the recommendations need to happen in partnership with the LIN or the Ontario Health teams, as our long-term care homes cannot always support how we would like to do things due to the lack of resources.
Right. Yep. No, and we understand this takes resources for sure. And certainly one of the good things about health teams is it's bringing together community-based organizations that didn't work together before. And interestingly enough, in my previous job, I was the CEO of the Change Foundation, which is a charitable organization based in Toronto, and we worked quite closely with the early adopters, the early Ontario health teams, to help them get their strategy together and to create an integrated sort of delivery plan for the community. This was way before COVID. And the health teams that did that work pre-COVID did well during COVID, because they knew that the organizations knew each other. They could rely on each other. If the home needed something, they could reach out to colleagues and they would step up, whether it was giving PPE or providing staff to go and do the communication to families. They just redeployed people. So having that community connection helped during pandemic, whereas in other communities with no health team and maybe the hospital administration and the nursing home folks didn't really even know each other, all of a sudden it was hard to start creating relationships in the middle of a crisis. So certainly you're absolutely right, those community connections and the ability to draw on other resources outside of long-term care, because we're all looking after the same patients and residents at the end of the day. It's markedly different when those connections are in place. Certainly the LIN piece of it, we certainly were in touch with the LIN leads early on, because we were hearing all of this information and wanted to make sure that their planning tables were aware. And in some instances, they were very involved in helping with procurement and, other issues. But again, it sort of was, there's 5 of them, and they each had different community expectations. But in some instances, they were quite involved in helping.
Yeah. Thank you, Cathy, and thank you. We've had some great questions. I think there was one last piece that I missed here. Earlier in the presentation, we discussed that some family members were unable to be with their loved ones when they were approaching end of life and ultimately palliative. When any resident is declared palliative at Monica's home, their loved ones are able to be with the resident's room as long as they're wearing their PPE. There isn't kind of restriction. So there are homes that are kind of, I don't want to say doing it right, but some homes are more
understand.
Yeah.
No, and again, you know, it's up to the home. So there's good progressive homes that understand the importance of that time. And there, as you can see, I mean, we had multiple examples of people saying, I didn't know. Nobody called. I had no opportunity to even ask to be allowed in. So being able to make the exception rule a rule so that homes have to follow it, and that's not voluntary, I think it's probably going to be important. But I'm glad to hear it's happening in some cases. It sounds like Monica's home is a really good home.
Yeah,
I think they're doing good things there.
Yeah, wonderful. Are there any other questions in our audience? So we've got a few minutes left with Cathy, and we've been so grateful for this this fulsome discussion, Cathy. And I know if there are questions that come in from our audience following today's session, feel free to direct it to the OARC team, and we can pass it along.
Great.
To Cathy and her team.
Be happy to do that. And I'm, you know, thank you for spending some time with me today. It's been my pleasure to natter at you. I'm sorry we can't see each other because there's so many of us, but I've appreciated the opportunity to speak to you today.
We've got one last suggestion coming in the chat box here. Everyone needs to hire more staff or team members. Are there programs, for example, like the Candy Striper program, where the government could offer money to students that could go towards their college tuition, and they could possibly gain some income as well?
Yep, there are. I don't know that there are actual programs in place this second, but there are certainly ongoing discussions about multiple models of increasing staffing levels, number of programs at community colleges, sort of volunteers, conversion, all kinds of stuff. There's a very good staffing report that was released about, I'm not sure now, maybe 2 months ago, with quite a number of recommendations that are being implemented. And a number of the associations, both long-term care and Advantage Ontario, have got very specific proposals about how we could deal with the staffing shortages in a really quick period of time, which are being paid a lot of attention to, because everybody, you know, at the heart of this, I think staffing is the issue. Once the staffing levels collapsed, that's when things started to fall apart. So that problem is still with us and needs to be solved.
Yes, our audience is echoing that sentiment. That the staffing is at the heart of the issue, and that there's been efforts to kind of fix other problems without fixing that problem at the core.
Yeah, and you know, we've known this for a while. We know what the PSW work environment looks like. It's not the best remunerated. In fact, it's probably one of the worst remunerated in the system. It's an hourly wage. People had to have probably 2, sometimes 3 different, you know, part-time jobs in order to make a full-time income, very little benefits, having to go between homes, not being paid for travel. It has not been a attractive work environment, and yet many of the staff love what they do and care for the residents that they work for and with. So, you know, the sector needs that particular group, and it's largely women, need to be better supported.
Yes. Thank you, Cathy, for speaking to that. And I know from the comments coming through, I know we've got a real mix of team members, residents, and other supportive partners of our long-term care sector and stakeholders participating in our webinar today. And there was some comments that the residents who joined us today say thank you so much for your time, for sharing this information. So
my pleasure. We'll do it again, you know, soon.
Wonderful. I think that's everything from the chat box, Josie Lee. Okay. So I'm going to send it back to my partner in crime.
Thanks, Melissa. And so with that, I'll just take a quick moment to thank everybody for joining us this afternoon, and a big thank you to Cathy once again for taking the time to to share and to update us on the important work that the Ombudsman Office is doing to support long-term care through this pandemic. And I know that OARC looks forward to continuing this relationship with you and your team. So thank you so much.
Okay, and hope everybody has a good afternoon.
Great. Thank you, everyone. Bye for now.
Bye-bye.